Now, it's with really great pleasure that I can introduce Dr. Kathleen Blake, who is a cardiologist and an electrophysiologist in Albuquerque. I think of her as an electrical doctor.
Yes, right.
She's been with the New Mexico Heart Institute since 1988, and in addition to being an outstanding electrician, she's been really interested in improving the health care of women throughout the New Mexico and the United States. Her interest in women goes back to about 20 years ago when she served as one of the founding coaches for Heart Disease and Women American Heart Association initiative in New Mexico. And that was far before anyone really realized that women have the same problem with their heart as men. And you're going to hear about more of that, obviously, tonight. She's also the 2010 chair of the American Heart Association Go Red for Women. And these little pins, the Red Dress program, has been very successfully in going around the country with these red dress programs to try and raise awareness of heart disease in women. In addition to education about women, she's taken the time to represent physicians in the American Medical Association delegate in 2006 and 2007. And then in 2004, she was the president of the New Mexico Medical Society. Her husband is a computer person and often comes up to Los Alamos and works out of Sandia. And I didn't realize that till tonight. So she's a tireless advocate for improving women's health care and heart care, and I really know that you're going to benefit and enjoy her discussion tonight. So, Dr. Blake.
Thank you very much. So I think, hooray, it's on. So first of all, thank you, Carolyn. Carolyn was one of the first people to welcome me to New Mexico when I moved here with my husband in 1988. And she has always been a person who's fostered both professional as well as community education. And I think that her work on the Heart Council is certainly a testimony to that. Couple of things. My husband does come up here fairly regularly. He's taught classes also for the University of New Mexico in their distance learning program. And then more recently through work he's done at Sandia Labs. We are profoundly disappointed that Los Alamos currently has the fastest supercomputer. That it is neck and neck, and Oak Ridge is trying to surpass both New Mexico labs, and I would just hope that that doesn't happen in the coming year. So, so many, many ties to this community. I wanted to preface my remarks about women and heart disease by saying, first of all, that I want to be especially sure to welcome and have so many men here in the audience. I think that a lot of what I have to say will clearly relate to the women in your life that you care about. But also, a lot of this is transferable information in terms of the heart care and health care for men. The other part is that most of my remarks tonight are going to really relate to the diagnosis and treatment and issues around coronary heart disease. But I'm hoping that during the question and answer phase that I can answer questions about other types of heart disease, if those are things that are really top of mind for you. So we don't have to limit it to just that. In terms of moving the slides forward, do I have something that will do that? Or do you guys do it? There we go. So the whole program about heart disease in women that we started to look at 20 years ago was originally called the Silent Epidemic. And it was called that because really, truly, in the post-World War II era, as Americans, we became very familiar with the notion that men in their 50s and in their 60s, still very much in the prime of their lives, were being struck down by what used to be called a coronary thrombosis, by heart disease. And we really, truly didn't hear as much about it in women as we did in men. What we now know is that close to 500,000 women each year in the United States die of heart disease. Compare that to breast cancer. With breast cancer, there are about 40, maybe 43,000 deaths per year of women. But if you look at the public awareness of the two conditions, I think that women are much more aware when they think about their own health about the issue of breast cancer. And I think some of that is because breast cancer is seen as predominantly, 99% of the time, as a condition affecting women. It is true that 1% of cases of breast cancer affect men. But so I think women have focused on breast cancer, and it's through programs like the Red Dress for Women, like the Go Red Luncheon, programs like this, that we've been able to get the word out that they need to also focus on their heart health. If you look at what I call the mismatch of perception and reality, if you ask younger women in focus groups what are they concerned about, they'll tell you primarily it's issues related to childbearing, rearing their children, ensuring the health of their children and of their spouses. They frequently will cite, and this is actually across all age groups, that stress is their major health concern. And certainly in these times, I think that all kinds of stresses are starting to come to the forefront. They are much more likely to worry about heart disease affecting the men in their lives as opposed to themselves. So what we've realized, they say the way to a man's heart is to his stomach. I think that the way to a woman's heart is actually through the men in her life. That for some women, they will make the changes because they are making them on behalf of the men that they live with. Heart disease is perhaps considered less of an issue for women because on average, coronary artery disease presents about 10 years later for women than for men. So men, you'll start to see that uptick in the 50s and 60s. For women, it's more likely to be in the 60s and 70s. So for women, it's more likely to occur at a time when child rearing is done. They may be done in terms of their work-related responsibilities. And so what you might consider some of the family and economic workplace impact is lessened, but it is not to say that that problem is not there. And then the other thing that I think has been an interesting mismatch is just the way we look at the two kinds of disease, breast cancer and heart disease, and we look at them and approach them very, very differently. We can go to the next. If we look at how well breast care is understood, it's extremely well integrated into the regular care, health care that a woman receives. Women consider it their disease. We hear about very young women having it, sometimes women even in their late 20s and their early 30s. It is something that you might say is visible. It affects the clothes that a woman might wear, the bathing suit she might wear. It is something that is seen as an externally apparent illness, whereas heart disease is more internal and may not be visible at all and doesn't affect necessarily the way that a woman presents herself to the world. The other part has to do with prevention. For the most part, women see breast cancer as something that they can't really prevent, but that their task is maybe a more focused task, which is to make sure that if it occurs, that it is diagnosed early. Whereas for heart disease, it is a tougher job because the key is to prevent it and so then hopefully avoid having it ever detected. You might think of mammography as easy. It's not 100% accurate. About 10% of breast cancers don't show up on a mammogram. But for most of the women in the room, certainly true for me, we've kind of got the drill. We go and get our mammogram either yearly or every 2 years, and we know that then it's sort of mission accomplished. Self-examination is now, I'd say, on the wane in terms of breast cancer detection, but early detection is clearly standard. In terms of women and heart disease, women think only men have it, but in young women who are smokers, they have a 7-fold increase in their risk of coronary artery disease. And the latent period for heart disease can be very, very long. There are studies done of Korean War casualties and fatalities in the war, seeing that plaque begins to grow even when someone is in their late teens. And so there's a blessing and a curse. It may mean that the disease has already started or already become somewhat established, but the blessing to that curse is that it also means that you have decades in which to make changes before, as we call them euphemistically, events occur, events like heart attacks. In women, one of the big challenges is that the symptoms are atypical. We'll talk about that in a few minutes, because I want you to know when you leave here tonight what's typical, what's atypical, and why do they keep talking about that in most settings, women versus men. It's a little harder to get pictures, accurate pictures, particularly with stress tests in women than with men. And that when I, as a physician, Carolyn Lineber as a physician, when any of us is talking with you, we're not just asking you to go out and do a test. We're literally asking you to change the way that you live your life. And again, sort of cup half full or half empty, the good part is that there are lots of different, what I might call targeted strategies. The bad part of it is that you need to do them. And so, you know, you really do have to make the changes, but those are all within our reach. The other thing I wanted to talk about and sort of bring this to reality is I want you to think about the visits that you have with your physicians. And this really applies to anybody, any visit, any time that you go into doctor, physician assistant, nurse practitioner, emergency room, wherever you go. Oftentimes the agenda is very full. Please make a decision before you go in for that visit. What are the top 3 topics that need to be addressed? Have some idea of how much time you've got. Because the worst feeling in the world for us, and probably for you, is that if you're the kind of person who sort of ramps up gradually, and the most important topic is coming in the last minute of the visit, you'll feel shortchanged and we'll feel like we did not do a good job. So have a very good sense of that. Make sure that you and your doctor, nurse practitioner, provider, capture each other's attention. You know, the magic words. This is the most important thing I need to talk with you about today. This is what I am really worried about. And also be really clear. Now, in some ways, this doesn't apply in Los Alamos. I mean, you have the highest number of PhDs in the country per capita and all of that. But different people do learn different ways. Some people are verbal learners, some people are visual learners, some people learn from another person. And so if somebody is giving you something and it's absolutely not in the way that you like to get information, but you prefer to be able to do an internet search or go to websites or listen to a tape or whatever, let us know that. Because most of us have all of those materials at the ready. So don't let us assume something that's incorrect. Think about when you go in, think about what we call your readiness to change. Physicians are now actually measured. We get report cards on how many of our patients, we ask them, are you smoking or using any kind of tobacco product? If you are using a tobacco product, are you thinking about or getting ready to quit? And that is to find out, are you ready to change? And therefore, should we spend some of our visit figuring out what might work for you? If you've tried quitting in the past, What were the impediments? What caused the relapse? What do you think could be done to address that? And quite frankly, if a smoker says to me, straight up, it's absolutely not something I can do right now. My wife's having surgery, my husband, just lost his job, this or that or the other thing. I say, fair enough, but I promise I will ask you each time you come in. And any time that you decide you're ready, in between our visits, call me up. Because when you're ready, we are ready to help you get that task done. Update your family history. It is important to us. It does matter to us. If you've had a family member who's had a balloon angioplasty, a heart attack, has had a bypass operation, in my field, if someone's had a pacemaker, if someone has died suddenly, unexpectedly, please let us know that. Because so often we go in and we're kind of, we're busy, we want to get other things done. Just give us the thumbnail sketch. Here are the things that happened in my family this year. You might need to know it as you're taking care of me. Identify, with the help of doctors and with your own thought process, what are my modifiable risk factors? And I've mentioned tobacco, but it also applies to cholesterol, it applies to weight, high blood pressure, and we'll go through some of the numbers in a little while. Ask your doctor to calculate for you. There is what's called a Framingham risk score, and certainly if you Google and you look at New England Journal, but a whole bunch of other sites, you can get a calculator, and it allows you to plug in your numbers and plug in your risk factors. And what's done, and I would tell you the scoring is not perfect, but it's good, is it will give you a ballpark idea of whether you are at low risk of a heart event in the next 5 to 10 years, meaning less than 10% risk, whether you are intermediate, which is 10 to 20%, or whether we consider you at high risk, meaning 20% or higher risk of something happening to your heart in the next 5 to 10 years. And the reason that's important is that I always have the notion that I wish, when I'm seeing somebody with a heart attack, I kind of wish that I'd met them 6 months earlier. And then what I could do is I could apply all of the therapies beforehand and perhaps prevent their heart attack. So risk analysis is important. Lastly, decide who's going to implement treatment. Is it going to be your, in a woman's case, is it going to be your obstetrician gynecologist? Is it going to be your internal medicine physician? Will it be a cardiologist? But get the line of responsibility very clearly delineated so that you don't have 3 different people all measuring your cholesterol at different times of the year, or all trying to change your medicines on you at different times, not knowing what the other one is doing. So clear authority. If someone says to me, my doctor takes care of that and measures my lipid profile twice a year, and here's the numbers, by the way, we're done. That as long as the goal is being reached, then I don't need to mess with that part of your care. We can spend the time on something else. In terms of classification, I thought the scientists in the audience would like the fact that we actually have a scoring system that's used to decide about any particular therapies. And I want you to just have a mental sense of this, because I think that there are always things that are coming out that will be sort of new technologies, new therapies, and they will, as they go particularly through the cardiology community sort of vetting process, a class 1 indication says that that it is an item that is useful and effective, and it has been proven in multiple randomized controlled clinical trials. So that is the highest level of approval or endorsement. 2A says, and this is typically when there has been a large but single randomized controlled clinical trial, 2A says that the preponderance of the evidence favors this particular item, whereas 2B says it's less well established, might be helpful, but think twice about whether this is something that is worth the time, potentially the risk, the cost, et cetera, in terms of receiving treatment. And then class 3 says that that particular item is not useful and in fact may indeed be harmful. And there are occasional shifts from these things. So for example, with hormone replacement therapy for women, that used to even in some scoring systems be as high as 2A. Well, it's now a 3. And so we'll talk about that some, but also I think it is fair game when you're with your physician to say, you know, at what level, how good is the data that I should really be taking this pill or having this test. And level of evidence is really basically there. And then lastly, what I call the generalizability index. And this just is sort of the, how good is it for the real world? Because randomized controlled clinical trials are just that. They are highly controlled. And what many of the studies now require is that they cite how many people they considered for enrollment and how many got in and met all of the entrance criteria and had no disqualifying elements. Because quite frankly, many studies, it will be 10% of the original pool actually got randomized. Go to the next. So estimation of the 10-year risk in terms of Framingham looks at age, which is obviously a continuous variable, total cholesterol, the HDL or good cholesterol, smoking actively, but also there is a decreasing curve or gradient based on how long it's been since you smoked. General rule of thumb is that by about 4.5 years after quitting smoking, that person's heart risk is the same as if they had never smoked. So when people ask you, you know, is it too late for me? The answer is no. Actually, it's never too late. And people who've gone all the way to having bypass surgery, if you look 10 years later, those who were able to quit smoking versus those who couldn't, there is a big difference in terms of survival at 10 years. High and systolic blood pressure, whether it's treated or untreated, and then I've told you the risks. We'll go to the next. Lifestyle interventions, tobacco abstinence. It turns out that of people who are smoking but wish to quit, the average number of times that they've tried to quit is 7 before they are successful. So if someone comes in to me and says, well, I've tried a couple of times and hypnosis didn't work, or the patch didn't work, or the gum didn't work, or this or that, I say, you know what, you are still a newbie. You are a newcomer to smoking cessation. And we really break down what are the factors that resulted in relapse. And it's very much the readiness to change, the willingness to tackle it again, and the knowledge that in the long run of smokers, 80% of those who wish to quit will be able to quit. So if it takes 7 tries, that's fine. Physical activity, minimum 30 minutes, 5 days a week. The problem I have with the 5 days a week recommendation from the Heart Association is then everybody's saying, well, tomorrow is one of my days off. And so they're really, you have to have a schedule. If you have to think about it too much, you may not do it. You can't wake up every morning with this notion of, I get to decide, because then it doesn't happen. And then it goes, we have a questionnaire in our office asking people how often they exercise. And I always worry about the people that say, well, it's 1 to 2 times per week, because then I know it's not an embedded habit in their lives. So for sure 5, but the days you don't exercise need to be named regular days of the week so that you really can't let yourself off the hook the rest of the time. Someone has had coronary artery disease, then I strongly recommend cardiac rehabilitation. It gets them better, quicker than almost anything else. And the reason for that is that if you've had a heart attack or you've had bypass surgery, most people are kind of shaky about what they should do or not do right after that. And with cardiac rehab, they will get you going faster than you would otherwise let yourself do it. And I think that people are sometimes surprised, sort of gee, I had no idea you would let me do that much so soon. Heart healthy diet, and I understand that there's a strong program here, in fact, a heart healthy cooking program that the council supports. Quite frankly, sounds like a lot of fun. And I think that people who enjoy cooking together also enjoy figuring out how they can make things much healthier for themselves and their family. I've put here the body mass index, or BMI. This is a calculation. You can even do it with a slide rule, actually. But it's sort of a logarithmic calculation, and there are calculators that are on the net, and oftentimes your doctor's electronic health records will have it. But it looks at your height and weight and makes an estimation of where you fit and whether you're in a good weight range, too low or too high. And also the waist measurement, which for women should be less than 35 inches. One of the big impediments to treating heart disease and preventing it is depression. And it's both depression after an event has occurred, but it's also depression on more of a chronic basis. And it's fundamentally that people who are depressed have a harder time maintaining healthy lifestyles. So we actively ask about that. We look at people getting treated for it because we think they then have the wherewithal to be able to take care of themselves, whereas otherwise it's very hard. Omega-3 fatty acids in high-risk women are recommended. This is the fish oil that you can get at a health food store, and certainly also eating what you might call oily fishes such as salmon, anchovies, things like that. And then a big debate about folic acid, but the bottom line is that women at high risk should probably be taking between 400 milligrams and a gram of folic acid a day. And then there is a big fight ongoing, but maybe soon to be resolved, about all the other B vitamins, et cetera. And it actually looks as though we should not necessarily be supplementing those beyond the recommended amounts. And similarly with antioxidants. I think the jury is back, and I think the verdict is in that vitamin E does not prevent heart disease. And that therefore people should not be specifically megadosing themselves with the antioxidant vitamin. If you look at major risk factor interventions, with blood pressure, we really want you to get to 120/80 or below that. That is what's considered a normal, in fact, optimal blood pressure. If your systolic blood pressure is up to 130, we'll still tell you that you're normal, but we'll want you to be sure you know from year to year what your blood pressure is doing. Above 130, it's considered pre-hypertension. And then above 140, it is considered hypertension. And medication is strongly recommended if the systolic is consistently above 140 or the diastolic consistently above 90. In terms of lipids, when I went to medical school, the slip of paper would come back and it would say what a normal cholesterol was, and they said that anything below 300 was normal. Well, actually, that's why we had an epidemic of heart disease in the 50s, 60s, and into the 70s, because that actually was average for Americans. And so average is not normal or not optimal in this case. So then in the 1980s, we dropped that level down to 240 for total cholesterol. And then more recently, we've dropped it down to 200. What also matters is what's the ratio and what are the different components. And your LDL cholesterol, to be optimal, should be below 100. Borderline is up to 130. HDL for women should be above 50, For men, it should be above 45. And then triglycerides should be less than 150. In terms of diet, we have recommendations in terms of the amount of saturated fat in your diet, the amount of cholesterol, and also reducing trans fatty acids, which are now have to be labeled or put on a label of food so you can tell pretty easily if it is one of the detrimental fats. Conversely, looking at plant oils, olive oil, nuts, things like that will have beneficial fats. We look at people in terms of high lipids and sort of group them into targets. And so if you've got somebody who's high risk based on their whole risk factor profile, and they've got a high LDL cholesterol, then we will aim to get that LDL below 100. And if they've got a low HDL cholesterol, we will try and raise it with weight training exercise, the healthy fats, meaning things like nuts and olive oil, or if we need to, with niacin, which is a B vitamin, and possibly also with prescription medication, what are called fibrates. Those are drugs like Lopid, Welchol, things like that. If someone is at intermediate risk, we certainly recommend that their LDL be treated if it's above 130. And then if they are at a very low risk, and I have to admit, I don't necessarily agree with these numbers. It says if someone has absolutely no risk factors and their LDL is above 190, think about starting therapy. In that person, I actually want to know a whole lot more. I want to know about their family. I want to know about their other risk factors. I may do testing to measure their particle size. I'm going to really drill down to make sure that if a decision is made not to treat, that it is based on a lot more data than just that one number. Go to the next. If someone is diabetic, the definition for diabetes is a blood sugar fasting that's greater than 125. And in that instance, there's a test, the glycosylated hemoglobin or hemoglobin A1C, that we aim to get that below 7%. Their LDL, we want it below 100, and their blood pressure less than 130/80. And the reason for that is that we consider anyone who is diabetic as if they already have coronary artery disease. And because that's what people who have diabetes tend to die from. And so we're going to make the targets very aggressive in order to lower that person's risk. We look at aspirin in high-risk women, so multiple risk factors, or they've had coronary disease before. We'll say anywhere from a baby aspirin to 2 baby aspirin a day. And in the intermediate risk women, we use it if they don't have side effects and therefore don't have problems with bleeding, et cetera. Beta blockers are drugs like metoprolol, carvedilol, low pressure, atenolol, et cetera. We use those primarily after heart attacks or to treat angina, cardiac pain. ACE inhibitors are drugs you may have heard of like lisinopril, Zestril, enalapril, captopril. These are drugs that are very good for hypertension and especially in diabetics. And what are called ARBs or angiotensin receptor blockers are good for the people who can't tolerate the so-called ACE inhibitors. Next slide. I want to talk briefly about atrial fibrillation. It's the most common arrhythmia that we treat. It's a rapid, irregular heartbeat, and when it occurs, the upper chambers of the heart are sort of quivering, and so they don't move blood through them as smoothly and as quickly as we would like. That promotes clot formation, or can promote it. And so we will use a drug called warfarin or Coumadin in people that we think are at high risk for stroke. There is a scoring system now that basically is a point system called the CHAD score, and that allows physicians to sit down with somebody and say, okay, do you have congestive heart failure? Do you have high blood pressure? Are you above age 75? Have you ever had a transient neurologic event or a stroke? And if so, and are you diabetic? And that helps sort out who we can treat with aspirin and who we need to treat with warfarin. And if someone has atrial fibrillation but they're low risk, they can be treated with 1 full aspirin a day. Next slide. In terms of things, the so-called class 3 items, hormone replacement therapy has moved to class 3. And in women who are on it, it should not be continued just in the hopes of preventing heart disease. And the notion now is that instead of being on it lifelong, that women should be on hormone replacement therapy for ideally no more than 5 years if they've had menopause at a natural age, didn't have a hysterectomy with removal of ovaries, and that it should be used to treat symptoms associated with menopause, which will be hot flashes, significant hot flashes, severe sleep disruption, things like that. Antioxidants I've mentioned, we've now put those in class 3. And in the low-risk woman, there is no reason for that woman to walk around taking aspirin every single day of her life. Now, what happened with hormone replacement therapy? I mean, there was this period of time when I and other cardiologists told lots of people that if they could take it, they should take it because physiologically it made sense to take hormone replacement therapy. And we thought that, based on observation number 1, there was the 10-year difference between women and men developing heart disease. And so if you have a 10-year difference, what's different between women and men? Well, it's hormones. And so it was thought that the estrogen naturally produced had an effective, a protective effect. There was a huge study looking at well over 100,000 women called the Nurses Study from primarily the Northeast. And it suggested very strongly that in that very large group, those who took hormone replacement therapy had far fewer heart attacks. There were a lot of things known about what you might call the physiology of estrogen. It's a vasodilator of blood vessels, or certainly of premenopausal blood vessels. It lowers LDL cholesterol, beneficial. It raises HDL cholesterol, so that should help. It seems to have some clot-busting activity, but as you can see further down, it may also contribute to clot formation. And then one of the things that we were not prepared for, but turned out to be very important, is the whole role of inflammation. And it turns out that estrogen may actually increase some of the inflammatory markers in a woman's bloodstream, and in so doing can increase their heart disease risk. We can go to the next. So there is what's called the healthy woman effect. If a woman is on hormone replacement therapy, or this was true certainly before the Women's Health Initiative study, she got that prescription from somewhere. This was somebody who got regular medical care, went in, saw her doctor, and had all kinds of things addressed. And it turned out that it was an association of just being more health attentive. As a sidebar, I would tell you the same thing happened with vitamin E. Turned out that people who bothered to read about vitamins, bought vitamins, took vitamins, were just more health conscious. So it was a marker for a healthier person in terms of their overall lifestyle. The second was the temptation really of what's called surrogate endpoints. And by that I mean that it takes years to do some of these big, long studies. And so what many of the original studies were is they looked at surrogate endpoints that could be acquired much more quickly. And that would be effects on blood pressure, effects on lipids. And so there were a variety of surrogate endpoints that looked good. But you had the new one, the emerging one, of the C-reactive protein, which measures inflammation. And it turned out with estrogen, that level rose. And that actually is associated with more heart disease. The other problem with a lot of these shorter studies is that if there's a neutral effect or a small effect, you might miss it. The study's just not powered to do it. And the same is true in terms of looking for adverse events, which if they are low frequency, you may not see them. Go to the next. So the Women's Health Initiative was really the seminal, the pivotal, the kind of ended almost all future studies of hormone replacement therapy. It was started in 1992. The women were divided into two groups, and one group was the women who had previously had hysterectomy. The other was the group that had not, and the group who'd had a hysterectomy received just estrogen. The group who had not received a combination of estrogen plus progesterone. Progesterone was to minimize risk of cancer of the uterus. Go to the next. And they looked at non-fatal heart attacks, coronary heart disease, death. They also wanted to know, because there's data that breast cancer risk is increased if you take estrogen, they wanted to know about that. And then they wanted to know about a bunch of what we might call some of the less likely to happen but still concerns, including blood clots to the lungs, uterine cancer, cancer of the colon, hip fractures, and stroke. Okay. And what was found is, to everyone's surprise, that in the Women's Health Initiative, the study for combined therapy, estrogen plus progesterone, was stopped just over 5 years into the study. And it was because there was more invasive breast cancer, and that was seen more in the women on therapy than on placebo. And it looked as though there was a low yield of continuing the therapy on the global index. And interestingly, for the heart disease stuff, there was an early increased risk, and then it became neutral. And what we think happened there was that the people for whom estrogen triggers blood clots, they all had that happen in that first 18 months or so. And they got out of the trial. Very similar to when a younger woman starts birth control pills and might then have a blood clot in her legs or a blood clot in her lungs. There are some predisposing clot abnormalities, oftentimes genetically driven, and you give that person estrogen and the clots come. And also, they couldn't really identify the high-risk subgroups, although it now looks as though one of the weaknesses of this study was that, on average, the women enrolled in it had been menopausal for 10 years. A very small number, about 2,500 women, had been menopausal or were started at the time of menopause. And they actually look as though they do okay, that they're not harmed. And it's probably because they've still got the molecular receptors for estrogen that they had prior to going through menopause, whereas all of that changes the farther you are into menopause. When the women post-hysterectomy, basically the same findings. So it did not say that hormone replacement therapy should never be given. That was the message that many, many, many women heard. And in fact, it was estimated that 40% of women who were on hormone replacement therapy abruptly stopped it. And what's probably more reasonable would have been a tapering process and an assessment of at what point they should be off of it altogether. We'll go to the next. So we've talked a bit about healthy woman effect. We've talked about self-selection. Certainly women who choose to go into randomized clinical trials are women who are generally going to be more health conscious and more likely to report when things are not going well. The timing, some self-reporting bias, and the fact that for some women, symptoms of coronary artery disease might have been atypical, so it made the sort function difficult. We'll go to this. So what are some of the issues? Why does regular estrogen that women make before menopause appear to be protective? And we now think that it's because of its effect on the lining of the blood vessel wall and on a balance of what are called these receptors for it and that balance is favorable prior to menopause, and the shift in receptors has an impact afterwards. The early adverse events we think are due to inflammation, which can trigger heart attacks, and we think it's also due to clot formation. And there have been a lot of people who then said, well, if the stuff that's made by a drug company doesn't work, or if it's not safe, then maybe I will take some of the botanical products. Mexican yams have a lot of estrogen in them. People said I'll switch to soy products. And my real strong reservation there is that they've not been studied in the same way. So eat them in normal amounts, but don't eat them in excessive amounts. And then also to how else, so if we're giving up some of the beneficial effects of estrogen in terms of hardening our bones, improving our lipids, we do now have alternative ways for doing that, so we don't have to rely on estrogen alone. So what happens if you think a woman has coronary heart disease and you're concerned about trying to sort that out? Many of you at various times in your life may have either used a treadmill or had a treadmill exercise test. It turns out because of estrogen effects, the EKG is not as accurate in women as men when they exercise in a treadmill. And so what we generally recommend is that a woman have a stress test, if you're looking for heart disease, a stress test that includes picture taking, either with a nuclear medicine picture, where you're looking at perfusion of movement of an isotope into the muscle, or with an echocardiogram. If you look at some of the new strategies, and you're trying to figure out, is this somebody in whom I should be aggressive about treatment? What we're starting to do is we're looking for plaque before it causes symptoms. So this can include a coronary calcium score. It is a very rapid CT scan that is not looking at the whole roadmap of the arteries, but it's just a snapshot that says this person has calcified plaque or not. And then that can help sort people who should have aggressive lipid management. A beautiful, non-invasive way to look at the blood vessels is to look at the carotid arteries, because you can see, is the wall of the carotid artery getting thick? Is it looking lumpy? Is there plaque there that needs to be treated aggressively? I would say the other place is in the eyes. Ophthalmologists frequently are able to see if there is some glistening and some plaque or clots that are forming in the blood vessels to the eyes. There's a test that involves giving medication that looks at the ability of a blood vessel to dilate. And the long and short is that blood vessels with plaque don't dilate very well, and healthy blood vessels do. We're able to look at, with MRI, we're able to do some other types. CT coronary angiography is a popular test, but I would tell you it's only merited in people where you're trying to avoid a heart catheterization, an angiogram. Go next. So in terms of community education and in terms of the signs and symptoms, the first thing I'd like to say, because people always say to me, well, I've heard that women are different than men. First thing I would say to you is that they may be exactly the same. They may have the same symptoms, the heavy, the pressure, the tight, the feeling like someone is giving me a bear hug type of discomfort is coronary symptoms. But it also can include an unusual degree of fatigue, not just the I'm tired, I did too much today, but the profound fatigue with activities that you used to tolerate perfectly well. And it can also, the same can apply with an unusual level of shortness of breath for activities that previously were fine and that you had no trouble with. And then there is the symptom of nausea, and people get nauseated all the time. We don't want you all coming in, if you're nauseated, to the emergency room thinking it's a heart attack. But the way I tell people is, if you're nauseated and you go to the bathroom and you throw up and you feel better, you probably just had a stomachache. You ate the wrong food. But let's say you threw up and you still feel awful. And in fact, you feel profoundly awful and terribly weak. Okay, plain old nausea from food poisoning or something is not going to do that to you. So then that should also be something that turns on a light bulb that says, I think I better go in. And then again, with women, there are all kinds of interesting studies that look at women's ability to communicate those symptoms. And what I would tell you is what helps me the most is if someone comes in and they tell me this is totally different than any nausea I've ever had before or any little ache and pain I've had in my chest before, and they can give me a comparison statement, then I've got a better shot at figuring them out and figuring out who needs to be kept overnight or who needs a stress test or who I can send home and be very comfortable that they will be fine. We'll go next. And so interventions, just briefly, in women with interventions, I would tell you that there is data that women don't do quite as well as men if they get bypass surgery or stents, but that's because they're typically older at the time they need them. They have smaller blood vessels, and so there's a little bit less room to work. But that would not be a reason to not recommend those. And there are ways that we are able to limit those risks. And then we'll go next. I think we're close. Keep going. And so the future, it's going to be early prevention in childhood and in schools. It's going to be obesity prevention and management. It's going to be, can we go to that next slide? There we go. Smoking cessation, and I would say making it so that people never start. Diabetes prevention, figuring out how we should really use the novel risk factors, and being able to have more public awareness about what are the signs and symptoms of a heart attack when it occurs. So I think I will stop there, and I'll be happy to take any questions. We might want to turn up the lights. Thank you. So, why don't you come up with me?
Very nice. So we're going to pass the microphone around, and please ask any questions you can.
Yes, ma'am.
First here.
Can you explain why it's more difficult to image women?
Yes. The question, for those who might not have heard it, why is it more difficult to image women than men? There are a couple of reasons. Excuse me. One is breast artifact, that if the imaging modality involves nuclear medicine, you may actually have to have pictures with a woman lying flat on her back, but then also have her turn over so that you can move breast tissue out of the way of the camera and be able to see better. The second is that with exercise on an echogram, women's heart muscle may not augment its contraction as well as you would see in a man. And so you kind of put all the pieces together, the symptoms, the risk factors, the imaging results, the exercise tolerance, to come up with an answer.
Thank you very much for your presentation this evening.
Yes.
Very informative. The question I have is very basic. You can answer in 5 seconds, maybe less than that. You were mentioning that women generally take baby aspirin just as routine self-care. What would you recommend for men for a situation like that?
So good question. And I would say first in terms of the baby aspirin, that it should be in women who are at intermediate to high risk. The low-risk woman without significant risk factors should not be taking aspirin for heart disease prevention. In men, the notion is that they too, baby aspirin is probably sufficient on a day-in, day-out maintenance basis, but the group that we don't want to treat with aspirin is the group with uncontrolled high blood pressure, because in the Harvard Physicians' Health Study, they found that there was a higher risk of hemorrhagic stroke if someone was hypertensive and took aspirin. So blood pressure's got to be controlled. Yes?
I've heard that there's a chemical test that's other than the treadmill test for stress test. Can you tell me about that?
Yes, there's several different chemical tests. One of them is what's called a dobutamine stress echo. It's actually giving a medication that mimics the effect of exercise. And it's for the person who cannot exercise, maybe an orthopedic problem or something like that. And while the drug is being increased and the heart rate's going up, you take ultrasound pictures of the heart. And you look for that improvement in heart muscle contraction. The other is the nuclear medicine tests that involve giving vasodilator medications, because as I mentioned in the talk, healthy blood vessels dilate, sick ones don't, and we then inject an isotope, and we're looking to see, do all areas of the muscles stay equal, or do areas of relative deficiency start to show up? So nuclear medicine and stress echo. Hi.
I have a question about clotting. Like, when you were talking about the ovarian hormones, increased factor 7 clotting activity and thrombin clot generation. Does warfarin address each one of those different types of clotting?
So thrombin is the end point, or it's the end product. So when a clot forms, it's because molecules of thrombin sort of glump together. There's a word for that. They form a matrix. It's a glump. It looks like a clot. But basically, warfarin does impact that whole clotting cascade. But you would not want to use warfarin unless you absolutely have to. So the better strategy would be for the person not to take estrogen.
Okay, but I guess what I'm looking at is, like, since there's several different types of things that cause clotting,
Yes.
like a lichen 5 factor and that
Yep.
kind of stuff, is warfarin the best type of thing to use to stop the clotting if you have several of those different clotting issues?
So, for many, many years, like close to 60 now, warfarin has been the only oral anticoagulant available to affect and to target at multiple levels in that cascade. It turns out that probably about a year ago, there was a drug called dabigatran that was approved by the FDA for use in the United States to prevent blood clots related to atrial fibrillation and also related to clots in the legs and the lungs. And its advantage is that it is a direct inhibitor of clot formation. And it's a fixed dose. If anyone in the room is on warfarin or knows people on warfarin, it's very hard to manage as a drug because it interacts with a lot of other drugs. It interacts with a lot of food. And so dabigatran has not yet been released by the FDA. But what we think will be very, very interesting is, yes, it will. Just if you look at the cost of the pill alone, it will cost more than warfarin. But what will the health plans do? Because the health plans are paying not just for the pills, they're paying for the blood tests that you have to go and get done all the time. And they are also paying for the higher rate of bleeding complications that are associated with warfarin compared with dabigatran in multiple head-to-head studies. So I think it's going to be interesting times. I guess I sort of believe in everything in moderation. And so I'm always skeptical if someone says that you have to have lots and lots and lots of something, because I don't think that's the way any of us live long term. And I also think that that then occurs with the exclusion of other things that we need to be eating. And so just as a general rule of thumb, if someone says, well, you need mega this or mega that, I say, so show me the safety data, the long-term data, because you're asking me to make a lifestyle change. You're not giving me a 1-week course of antibiotics. You're actually asking me to take something for many, well into the future. And I think that if they are unable to give you the data about the long-term high dose, then I'd say proceed with real caution. Yeah.
Question over here.
Yes?
Is having a resting heart rate less than 50, is that a risk factor for heart disease?
So the question has to do with, is a slow resting heart rate below 50 beats per minute a risk factor for heart disease? And the answer is no, is the bottom line. That if someone has no symptoms at that heart rate, energy level's good, and if they are able to appropriately increase their heart rate in response to exercise, then it's not an issue. That the person, and then the second part is that as we get older, our heart rate naturally tends to decrease. And so, I remember guessing what gender my children were before they were born. And the daughter had a heart rate of 156, and the son a heart rate of 125. Well, we'd never accept those heart rates in adults as normal. So we slow down as we get older, but it's not a specific risk factor. It's got to be symptoms. Yes?
I have a couple of questions about statins in women.
Sure.
And whether or not the drug studies that have been done on these have really included enough women in the trials, or whether the data that they got from men was extrapolated to women. And then the other question I have is, if a woman is on statins, at what age would it be reasonable to take her off those eventually? I'm one of these people who has a lot of drug side effects.
Mm-hmm.
I would rather not be on a drug after a certain age if I don't have to be.
So there are actually about 3 questions there. One of them is, and you've alluded to it, is the challenge with many studies up until about 20 years ago was that they did not include a sufficient number of women to be able to make convincing statements about therapies or not. More recently, certainly in the post-heart attack studies, the diabetes prevention studies, women generally comprise 25% or better of those large studies. And it's actually now a requirement for NIH funding of those trials. So I think with statins, there have been a bunch of different ones evaluated. The earliest one was Mevacor. It was evaluated at a time when women were rarely enrolled. The newer drugs, both looking at Lipitor, Crestor, which are the 2 more recent statins, plenty of women have been studied on those. Pravachol and Zocor, intermediate. The second component is someone's told me I need to be on statins. How long do I need to be on it? I think almost every cardiologist would say that if you've had a coronary heart disease event, or if you're diabetic and essentially have coronary disease by virtue of being diabetic, that statins are, so to speak, forever, or for as long as someone can take them. But no one will ask you to remain on something that you cannot tolerate. There are a bunch of tricks with statins. I sometimes have people on very low doses once or twice a week, and they're then able to tolerate it but get at least some benefit. And then the third issue has to do with, okay, I'm going along and things are going pretty well, but I'd like to stop the pills. The issue is then that the adverse cholesterol profile comes right back. And so then the notion is with plaque is that active plaque is the plaque that cracks, the plaque that ruptures, the plaque that causes, euphemistically, events in people's lives. What statins do is they sort of deactivate plaque so that it's no longer growing. And so within 6 months of when a statin is started after a cardiac event, the curves split, and you see significant differences in events of heart attack, stroke, things like that. So there are no studies, big ones, looking at discontinuation. There are some small ones that say if a person abruptly discontinues, then their plaque may be prone to grow quickly and rupture. There are more events. So it's complicated. But long-term medication has to be reasonably well tolerated. And you have to try a bunch of different things with some people for it to work for them too. I mean, none of us wants you to feel sick. So.
Okay, my question has to do with CoQ10.
Yes.
That is pushed so often. Is that useful in arrhythmic heart problems?
So CoQ10 is an enzyme that we naturally make, and there is some data to suggest that it is lacking in people who have cardiac disease, and therefore the notion is that supplementation with coenzyme Q10 would be beneficial for those individuals. And I would tell you, I think it's still a work in progress. I don't think that we know what dose is the right dose. I don't think we necessarily know what happens to the coenzyme Q10 once it hits the stomach and how much of it we absorb. There is some data, interestingly, that coenzyme Q10 may help the person who cannot take statins. In terms of muscle aches and pains, it may actually enable them to take statins. But I think the overarching answer would be, I don't think we know enough yet. And it certainly is not enough for it to show up in any of the guidelines at the level of evidence that we've got. It's not either a plus or minus as yet.
On that same question, did you say people that don't have it could use this?
Oh, so there are some what are called observational studies that have shown that people, particularly those with weak heart muscle, are deficient in coenzyme Q10. So they're able to test for it. It frequently involves muscle biopsies and things like that. So I wouldn't necessarily go that direction, but that's where the logical extension to then saying, does treatment make a difference, come in. But I'd caution you, because that's where we thought with vitamin E that it was beneficial, and we then found that it wasn't. It's just like the estrogen issue. When women became so-called estrogen deficient, at menopause they had more heart disease. But giving them estrogen turned out not to correct that pattern.
Would you comment on the C-reactive protein, and if you have high levels, should you be treated in the lab? There was a report not too long ago that said if you had that but no other signs, you should consider going on statins. That was the drug companies, I'm sure.
So C-reactive protein is, it's an inflammatory marker. So the first thing is to make sure if you have the test done, that it be done at a time when you're not sick with something else, you're not recovering from an operation, and that you don't have some other reason for your inflammatory system to be kind of revved up. So it needs to be like a healthy time in your life. The second, with regards to C-reactive protein, I see it as value added, in that I use it as a tiebreaker. let's say someone is sort of borderline high cholesterol. We're going back and forth about whether to treat them with cholesterol-lowering medication. If they have a very high level of C-reactive protein, I will tend then, that's sort of my tipping point towards saying, let's treat, because the statin drugs will lower that inflammatory marker. But I do not use it as a single decisive test. Carolyn, how do you use C-reactive protein?
Well, the Jupiter trial suggested that you could use it to follow people's risk assessment, but I don't think we know enough yet, but it's an interesting marker.
Yeah. And people think that that's part of the benefit of aspirin. We used to always say that aspirin's benefit was by preventing clots, but it may be that even that little dose of aspirin, because of its anti-inflammatory properties, is working to counteract the effects of an elevated CRP.
Could you comment on red yeast rice?
Yes. Red yeast rice, which I always get sort of tongue-tied. I wish I knew why. But it is basically statin. It is the same statin as what used to be called Mevacor, or is now available as a generic called lovastatin. And so a number of my patients who just philosophically don't wish to take prescription drugs will use red yeast rice. I personally have no objection to that. But my request, if they're using it, is that we follow their lipid numbers, we make sure that they've gotten to goal, and that they always make sure that their pharmacist or any other person taking care of them knows that they are taking it, so that we can avoid interactions with other drugs. Because I think sometimes there's the notion that a supplement isn't a medicine and doesn't merit the same degree of caution. And so with red yeast rice, I don't mind if people prefer it, but I just want it to be treated as a medicine.
Could you comment on evaluating lipid profile target values for, say, like if total cholesterol is, say, in the 250s, but the HDL is in the 70s or 80s, and LDL is under 100? Do you,
So that could be,
in terms of starting medication?
absolutely wouldn't. So, I mean, my first quick comment is if somebody has an HDL that's in the 70s or higher, they could sell it on the black market to someone else. I mean, honestly, really, truly. We actually think that high HDL cholesterol somehow tracks with longevity genes. And there are families that have HDLs over 100 and seem to be unusually protected from all kinds of aging-related processes. So, but what you're pointing to is that not all total cholesterol numbers are the same. And the key is the ratios, or actually what each and every element is. So on a total cholesterol, every point that you have of LDL contributes 1 point to your total. Every point on your HDL contributes 1 point to your total. And then with your triglyceride number, you divide it by 5. So, for example, in a total cholesterol, if you've got a triglyceride level of 150, then 30 of your total cholesterol points will be from triglyceride. Because every HDL point adds to your total cholesterol, you have to know what it is in making those decisions. Because someone may have absolutely good numbers, but not know it if we only measured the total. Question in the back there? Okay, yes.
I heard that pomegranate juice helps lower cholesterol, but then in the same hand, I heard that it also interferes with Lipitor, which its metabolism, which then can increase the toxicity of Lipitor. What have you heard about that? Similar to grapefruit, you're not supposed to take grapefruit if you take Lipitor, because it interferes with metabolism.
I've not heard that with pomegranate juice. Carolyn, have you heard anything? Because certainly,
Not with pomegranate juice.
yeah, grapefruit juice is an issue. And sometimes people thought, well, if I drink my grapefruit juice in the morning and then I have my medication in the evening, but unfortunately the effect of the grapefruit juice is persistent throughout the day. And so you really can't be on the grapefruit juice with a variety of medications. And no, I have not. Nope. That's when we're, and I sometimes wish I knew everything, but I don't. And so that's where I would ask a druggist, because actually the people who know everything about drugs or can get their hands on every just sliver of information about drugs is your pharmacist. And so I'm calling them all the time about new drugs, drug interactions, low level, low frequency interactions. And it's sort of a bit of a plea to say that always think about, if at all possible, getting all of your prescription medications from the same druggist or the same mail order pharmacy, because it does help you stay out of trouble. And I used to think that those questionnaires of, where they always wanted to know, like, what other drugs are you taking? And I always thought that was Big Brother trying to, be very nosy. It's not. It's actually for your safety. So, yes.
I've got two questions. One is about taking a thyroid medicine, and I thought I know you're supposed to wait half an hour before you eat anything.
Yes.
Then I'd also recently heard that maybe you weren't supposed to take any other multivitamins for several hours after that, because it would interfere one way or the other. And the other question is related, is there a calcium factor related to heart disease, and how should you really get enough calcium? Because I hear, even supplements aren't that good, but that's almost the only way to get the big amounts that they're talking about these days.
So several questions in that question. Number one, the endocrinologist that I work with and taking care of my patients, all say you really do need the half hour to get predictable absorption of thyroid hormone, not interfered by with anything else. So it is a bit of a nuisance, but you need to do it. No, half an hour. Half an hour. In terms of the multivitamins, I think the same half-hour separation applies. I've not heard of any specific, that you must take it later. In terms of calcium, the issue there with calcium, I think they're twofold. People sometimes hear me talk about calcified plaque in the coronary arteries and elsewhere, and then they wonder if they should cut back on their calcium intake to avoid that so-called hardening by calcium of their arteries. And I'm here to say, no, you don't need to worry about that, because basically 99+% of the calcium that you take in goes directly to your bones. And so you're not going to either accelerate or decelerate plaque formation based on your calcium intake. In terms of a new thing that I am seeing measured a lot is vitamin D. And it turns out, and I hope that we are truly measuring the right thing. I'm not convinced of that yet. But that many, many people are vitamin D deficient, and so are now being told that they should be on vitamin D supplementation in addition to the calcium that they take. And there are a lot of theories. Maybe it's that we're all using more sunscreen. Maybe it's that we work more hours per week and we're not outdoors as much. We think vitamin D may help prevent heart disease, it may help prevent cancer. I'm getting to the point where, having seen us go through the hormone stuff and the vitamin E stuff and the vitamin C and everybody else, I'm sort of in a bit of a wait-and-see mood when it comes to vitamin D. So.
Yes. I'm not sure this is a well-informed question, but I think I've heard that a certain percentage of people who have heart attacks didn't have any precursors, and it was some electrical thing. Could you address that if that is true, being an electrician?
Right. There are a lot of
thinking of ventricular tachycardia.
Right. I mean, I'm almost thinking that, you know, we use the word heart attack when something very sudden and very abrupt and potentially causing loss of life happens to someone. And the actual loss of life, the stopping of the heart, can be caused by clot formation in the arteries, so that there's an abrupt destabilization of the electrical system of the heart. And so what you might call sudden cardiac death and heart attacks caused by clot overlap a lot. But there are heart attacks associated with clots where the person, their heart continues and they don't die. And there are also other causes of sudden death. Sometimes medications, sometimes familial propensities that can be completely independent of clots. So I'm wondering if that's where that discussion you heard or read about came from. So, yes.
Hi. I have severe osteoporosis, and so I've been trying to boost the bones and whatever, and increasing the calcium, magnesium, boron, and vitamin K, which has my doctor a little concerned because supposedly that thickens the blood, and I do have cholesterol problems and stuff like that too. And I was wondering and I'm taking vitamin D3. I was real low, so she gave me like 50,000 units each week, and now I'm getting back up. But I'm just wondering if that combination, now I'm trying to build my bones and do the muscles and the whole bit.
Are you going to hurt something else?
Thickening my blood with vitamin K, you don't think so?
No, I don't think so. The things about vitamin K, and just for people maybe less familiar with it, vitamin K is a necessary, what we call cofactor. It's required by the liver to make clotting factors. So the way warfarin works is by blocking the effect of vitamin K. So then the notion is, or of what you're wondering is, does having more vitamin K, is that harmful? But we make vitamin K already in our gut. The bacteria in our colon make lots of vitamin K. And there are plenty of foods that are very healthy foods, like broccoli, that are loaded with vitamin K. So if someone is not on warfarin, I don't worry about it, because the liver then has all the vitamin K that it needs to make those clotting factors, but it's not as though it's going to overproduce them. Yes? Sure.
I recently heard that the chicken and fish diet that we've been led to believe prevents atherosclerosis actually doesn't.
So I think I know a lot of people work in government-related things here, but I think we're all getting a little tired of the government, because it's like the government, turns around every 10 to 20 years, and it redoes the food pyramid. And then you say, well, what was wrong with the last one that you thought was so wonderful when you put it out there? And I think that nobody really knows. I still believe that the chicken and fish, because they're good sources of protein, are good food sources for people. But at the same time, you have to have some reasonable intake of fat, and you have to have some carbohydrates. And I think that where we went overboard as a country is that at the same time that we went to chicken and fish, and we went away from beef, that we also went very heavy on carbs. So I actually don't think we're going to be able to sort out or separate the two. There is data, primarily from Dean Ornish, who's done a lot of heart disease prevention and then prevention after heart attack research, that essentially being on a vegetarian diet can put people at a much lower risk of heart disease than they would otherwise be subject to. But no, I mean, I still think chicken and fish are fine because I think they're relatively low fat or often low fat or healthy fat sources of protein. So, yes?
Yes, I wonder if you could go into a little bit more detail on some of the symptoms that are more common to females having a heart attack. I mean, we've been told that we don't get the crushing chest pain normally that men get, and I don't think we always get nauseated when we have, heart attack or cardiac event. I just wonder if you could go over some of the common symptoms that a female would have.
So I think part of what I would try and correct is that women can truly have all the same symptoms as men, that they may, just like a man, have that discomfort in their chest. What's interesting to me is that when I ask people at the time of their heart attack, and I know they're having a heart attack because it's on their EKG and it's there for all to see, and I will say to them, tell me what your pain is like. Women and men alike will oftentimes say, it's not pain. And I'm like, what is it? And it's heavy, it's pressure, it's someone put a load of books on my chest, someone sat on my chest. For women, it will be, I feel like my bra is too tight. Or they'll say, I feel like I cannot get a full breath. I feel like something is constricting me from getting a full breath. So it's that sort of stuff. Now, I would also say, and this is true for women and men also, that if it's that quick sensation, comes and goes, lasts for a few seconds, and then it's gone, it's not your heart. Okay, those quick, brief things are typically musculoskeletal. There's a little muscle that twitched, or a rib that got sore, or cartilage that was inflamed. But then going to the other symptoms, the nausea, I think, is pretty much as I've said. It's that it didn't get better when I threw up. I still feel awful, and it's not going away. That, I think, is the tip-off there. So.
We'll take one more question here, and then I know Dr. Blake would be willing to stay afterward to answer any of your other questions.
Yep. And I'm not offended at all. If people also have heard enough, done enough, need to head home, you're not worrying me or Dr. Lineber or any of the members of the council. So you're a hardy group, but you're also welcome to go. So, yes. There you go.
I'd like to revisit the hormone therapy. I understood that if you had a hysterectomy and you'd been on hormone therapy for years and you had no adverse effects, that the study that you were mentioning, where everybody jumped off of it immediately, did not necessarily apply to you. Does it?
So, many women have had hysterectomies before and have had their ovaries removed before they went through menopause. And so they were immediately started on hormone replacement therapy. And so they never went through that alteration of their receptors. In terms of heart disease, they are not going to go through that dip, that 18 months where the risk is increased, such as was seen in the Women's Health Initiative. And the reason is because they never had that gap. And I think there's not a physician or woman alive who would say that a woman who goes through early surgical menopause, I don't think anyone would say she should not be treated with hormone replacement therapy. One of the advantages she may have, though, is that because she no longer has her uterus, she does not need to be on progesterone. And the thinking is that progesterone may account for some of the adverse effects that are seen with combination therapy. Over time, there is the issue of breast cancer risk. It turns out the largest per capita, or per 100,000 lives, group for breast cancer is women in their 80s. Okay, we hear the stories about the people in their 30s, their 40s, etc. But it actually turns out that it's the older age group that is at the highest risk. And so the recommendation is that at what might be someone's natural time of menopause, that there be consideration to cutting back. It might be over a period of several years, but to minimize that woman's long-term risk, not so much of heart disease, but really of breast cancer. So, cirrhosis risk. Right. So then the thinking there is that when women go through menopause, that they start to lose bone density, probably due to lack of estrogen. And so there is some osteoporosis benefit to continuing to receive or have a source of estrogen. The thinking, however, is that that may not fully offset the potential risk of breast cancer. And so that's where the individual discussion with someone's doctor and where the family history comes in. Because if you, let's say that your mother had a hip fracture from osteoporosis at the age of 70, or you yourself have had to be on steroids for treatment of asthma, or perhaps you had a period in your life when you, unbeknownst to you, you were hyperthyroid. There are all kinds of things that contribute to osteoporosis risk. So if someone has osteoporosis, then there may be more of an argument towards keeping them on hormone replacement therapy a bit longer. But the advantage now is that we do have other products that can be used and other strategies to prevent or slow down the progression to osteoporosis. I'm not saying that. I'm saying that it's individualized benefit, that I think each woman has to decide for herself, looking at her own family risks. And I think that if you're diagnosed with osteoporosis, you really have to say, okay, what are all my choices in terms of treatment? And is hormone therapy or ongoing hormone therapy an important part of this? Or is there something else like vitamin D supplementation, like some of the drugs that actually can reverse osteoporosis, things like that? So I think I'm coming around and maybe not saying it. It's very individualized. I don't think it's one size fits all. That what clinical trials do is they give you some broad generalizations, but they are in very selected groups of people. And so I think that there are a few black and whites and then lots of gray in between. So.
Thank you very much, Dr. Blake.
Thank you. Appreciate it. Great audience.